I remember the first time that I wanted to be a doctor. I mean, it was 1973. Okay. And I remember that day vividly because I was sitting in my pediatrician's office with Mom. And I'm originally from Puerto Rico. And so I'm sitting there visiting the pediatrician, and there was this room that he called a waiting room that was all panel wood, oak wood. It was all fake. Humming air conditioning, those that you put in a window. The center of the area where we were sitting and waiting for the pediatrician to call me in had the little toy boxes of trains with the books of probably the Three Little Bears, which have been used so much that the pages are torn. And the distinct smell of alcohol, not the one that you drink, but the one that you actually use to sanitize, permeated the room. And I do remember being the only child in that place. Mom was probably reading Reader's Digest because that's what we had in doctor's offices back then. And I was kind of sort of studying the little toy train station there, the wooden toy store, figuring out whether I was going to read Goldilocks and the Three Bears, or maybe Cinderella and the whole story with the prince, you know, killing the dragon. When all of a sudden this person comes out of where the door leading to the exam rooms was, and it was a pediatrician, and he was cloaked in his white coat with his stethoscope, with the drum being the size small enough to make sure that you auscultate a child and not an adult. Back then they weren't hanging things off of it, so that was it. Slick black hair, trimmed, very carefully cared for beard. A manner which he walked and talked to the outcoming mother and child gave him a sense of reverence. And turns around and talks to his assistant, scheduling his next appointment for this child. And so I saw him, and I remember standing up from my chair, walking up to him, tugging him by his nicely pressed white coat, and saying to him, "When I grow up, I'm going to be just like you." Now, he did probably look down at me and said, "Right." But 20 years later, I did actually enroll in medical school. Now, I will say that my trace career to medical school wasn't what it was back then. I actually went into this really cool thing that seemed to be attractive to me when I went into college, which was called computers. Now, this is 1985. All right, there's no internet, there's no cell phone, there's no iPad. The microchips that we utilized to record our videos were actually these things that looked like LPs. The computer lab was an area located in a particular building that you had to sign in. And the computer boxes that IBM were putting out there that were supposed to revolutionize the world were kind of the type of things that you had to almost press like an old typewriter to make sure that you clicked the adequate letter and code. And I went into college thinking that I wanted to be a computer programmer. Boy, I wish I stayed doing that. But I quickly found out that that wasn't my calling. I like people too much, so I finally decided that I was going to forego my first year of studying computer programs. I did hand in my final test for computer program blank. And just like that guy that actually from the Bills that walked out at halftime and said, "I'm retired," I retired from computer program back then in 1985 when I handed in my computer program exam blank. And I decided I was going to go into medicine. Sure enough, despite the fact that Mom almost had a heart attack when I told her that I wanted to be a doctor, she said, okay, well, she hung around with it, and sure enough, I became a doctor. I was fortunate enough to be one of the first residents that went to a good old Southern college called Duke, in which the Southern blood was running very strong through their bloods. And having a good old Puerto Rican boy from the deep South was just different. And then I was fortunate enough to be selected as one of the 2 cardiac surgery residents to train under some of the leaders in cardiac surgery at a place called, you may have heard of this place, Cleveland Clinic. And then after my first year, I was fortunate enough that I was actually asked to stay on staff. So great story, great trajectory. The journey has gotten me, only better. But what's happened over the time is that I've always sought my own interests. And in doing that, one of the things that I always promised myself was that at some point I was going to serve the people that most needed it in some shape, form, or fashion. And so back in Cleveland, what I did is I followed my passions. Now, let me tell you that I am not nearly as well known in the surgical community for structural heart disease and my real passion, which is mitral valve disease, than I am for transplants. If you ask and search my name and search in the community, you're going to say, oh yeah, the chief of heart transplantation that was at Baylor. But my true passion had always been structural heart disease. Now, it makes sense, right? You change the structure of the heart, a valve, a wall, an ASD, right? That's changing the structure. Or you take the whole motor out and you put a new motor in. Well, structural heart disease, the way that I look at it, right? Except that one is actually ultimate fighting and the other one is a little bit of finesse surgery. But I always been interested in structural heart disease work. And so what I did early on is I decided I was going to serve the community by creating a mission trip. And so this is me operating not in Cleveland Clinic. This is me operating in a third world country, the second poorest country in the Western Hemisphere, Nicaragua. What I did is I brought in everybody from Cleveland Clinic, next slide, to this rural, underserved town of Leon, Mexico, and I operated on people. Well, the interesting thing was that there were 300 people on a waiting list to get operated on. And different from the United States, in which when I walk in and I tell somebody you need surgery and they start crying, they crack their knuckles, all over there, it was celebratory. Everybody celebrated the fact that they were going to get operated on because they were going to die. They understood the consequences of their lesions. And they understood that they were being impacted not only in their quality of life, but also quantity of life. And so it was a very different experience. The other interesting thing about Nicaragua that I always said complimented and made me a better doctor was that the resources weren't there. Let me give you an example. When you had to pre-op somebody, heart surgery, well, you're probably going to need some backup blood just in case they bleed, right? Well, the closest blood bank is in Managua, 2.5 hours away. So what we had to do is start the case. The family members would rush to Managua to the blood bank with a cooler and ice, grab the blood from the blood bank, sign it off, and bring it to the hospital we were operating on. That's how we did surgery there. God forbid that there was an aortic dissection while we were doing the case. We had to get creative because there's no tube grafts that we get off the shelf. How is it that we were going to leave? How was going to remedial that? Or something simple as, well, atrial fibrillation when the defibrillator paddles are not working because the electricity is going on and off. And we're operating at 95-degree temperatures in the operating with our headlamps, with our gowns. I mean, it's true third world country, but we did it. The other interesting thing that I learned with time was this. Next. Most patients don't suffer the same diseases that we have here in the United States when it comes to mitral valve disease. In fact, what most people suffer over there is of rheumatic heart disease. And you understand it. Why? Now, I see a lot of people in their heads like, you're not telling me anything this, But you know, the problem is that they don't have any therapy. Bruce, can I get you to change the slide? They don't have therapies against this. They can't treat rheumatic fever because they don't have antibiotics. Because some of these people are living hundreds of miles away and don't get the care that they need. So the most common valvular abnormality that I dealt with when I was in Nicaragua wasn't coronary artery disease, because they couldn't get old enough to survive to have their coronaries affected by chronic diseases. They suffered of maladies that were acquired that today in the United States are rare. And so we saw a lot of this, of people that had mitral valve stenosis. Now with that, I was armed with a really interesting career, because while I did transplants, I really tried to develop my mitral valve and structural heart disease skill sets. And so, you know, next slide. You know, what I did find out is that, as you all know, in the United States, it's a completely different cadre of diseases that we face when it comes to structural heart disease, particularly when it comes to the mitral. And you can see that there are 4 common causes, rheumatic being the most rare. But we definitely see a lot of people that have the first 2, which are degenerative and ischemic mitral valve insufficiency. Now you're going to be somebody in the audience is probably asking themselves, why is he taking us through this whole story if he's supposed to talk about atrial fibrillation? I'm getting there. Give me a minute. The reason for this is, next slide, is that while degenerative mitral valve insufficiency, which is what we most commonly treat with medicines, next slide, and it's affected by this weird myxomatous disease of glycogen storage called myxomatous valve degeneration. The end result of not treating is this, next. Congestive heart failure, but more commonly, atrial fibrillation. So it's not uncommon for us in our field that when people come in, they actually have atrial fibrillation as part of their sequela. And the problem is as you can see, once symptoms start associated to mitral valve insufficiency, and that is even including atrial fibrillation, the clock starts ticking. And I'm gonna show you in a minute what are the current guidelines to refer patients to mitral valve care. And they include symptoms that may actually be caused by the mitral valve, including atrial fibrillation. Next slide. Now, you know, atrial fibrillation can be caused by a number of factors, okay? And while I'm going to focus my presentation in structural heart disease, you need to know that there's a number of diseases that actually cause atrial fibrillation. I mean, ischemic heart disease, valvular heart disease. There are medicines that cause atrial fibrillation. There are congenital conditions that cause atrial fibrillation. But at the end of the day, what you as a physician, or we as physicians, are trying to avoid are the end consequences associated to atrial fibrillation, which are stroke, which I bet there's not a single person in this audience that has not had a patient that has actually had a stroke, or a patient that's had a stroke because of atrial fibrillation, despite the fact on being what we believe is adequate medical therapy. And so the 2 things that we're trying to avoid in managing and treating people that have atrial fibrillation is stroke, and then secondly, heart failure. Why? Well, heart failure is actually the #1 cause of death associated with cardiac disease. And so these all then sort of add up in terms of patients that suffer this type of pathology. Next. Now, the therapies are #1, you got to treat the underlying cause. Whether it's medicines that are causing them, whether it's coronary disease, whether it's sick sinus syndrome, whether there's a structural problem with the valve, that is the first job, to treat the underlying disease. But really the acute goals associated to that, and I'm going to tell you, I talked to electrophysiologists, I talked to cardiologists, I talked to the PCPs and primary healthcare providers, And the bottom line is that I don't think that it matters necessarily, although you can find a statistically significant difference. Please spare me, I get it, between one medicine and the other. The goals are very simple. Slow down the heart rate, okay, to alleviate the palpitations, the symptoms that are associated to this, okay? And the second one is prevent from somebody having a stroke. Those are the goals, okay? And if you can do that effectively, then you're winning. But the bottom line is that you have to treat the underlying cause. The atrial fibrillation is a sign of something that's going on with the heart. And we got to figure out what those things are. Next. Now, I'm going to briefly touch on a couple of things that are done effectively as to trying to get people out of atrial fibrillation, and one of them is cardioversion. And, well, I've always watched it on TV. And and I do it too. I don't do it in patients in the cath lab, but I do it in the operating room. And when I see it, it's really dramatic, right? They're jumping off and all through the table. And when I tell patients that we're going to have to give you a quick shock when they're awake if they have atrial fibrillation, their reactions are like, oh yeah, that's okay. And I'm like, what part am I missing of this story? Because maybe I'm the only one watching the shows, but it's pretty dramatic. But the reality about it is not that dramatic. But we all know that cardioversion has a really good success rate. The problem is that the time that you stay in normal sinus rhythm varies, and it varies about the therapy that you're treating them with. It's a combination of electrocardioversion, but also it's important to you to keep in mind that you have to continue the antiarrhythmics for a period of time and potentially even anticoagulation. But a lot of people relapse. Next slide. And as I mentioned, basic medical management will continue to be rate controlled and anticoagulation, particularly for patients who continue to be in chronic atrial fibrillation. Next slide. Now, there are therapies out there which are very successful. And if you talk to your electrophysiologist or your cardiologist, you'll know that they can do things for patients that continue to be in atrial fibrillation despite being maxed out on the medicines to try to slow them down, to try to make them feel better, or try to prevent them from having a stroke. And so certainly, nodal ablation has become a very, very common one that we do, not I, but the electrophysiologists do, in trying to avoid people going into atrial fibrillation. But it comes with a price, which is basically the need of a pacemaker after that. And then certainly the pulmonary vein ablations that are also done with a very high risk, but a very low risk, but a very high success rate, are done also with catheters nowadays. And so I personally typically see patients when they are refractory to all of this, and we basically then have to do something surgical, not only to treat the atrial fibrillation, but more commonly to treat some other valvular heart disease or structural heart disease that they have that is causing them to have the atrial fibrillation. All these therapies are basically administered by the cardiologist, and only you come to surgeons when all these therapies have failed or are not working. Next slide. So let me go back to the structural heart disease piece, which I'm very interested in talking about, because we see a lot of this, and because of this, we started about 1.5 years ago to 2 years ago a mitral valve program at Baylor and Fort Worth to allow people that have this type of problem to be treated effectively. And I'm not going to talk about pulmonary hypertension, but you all know pulmonary hypertension affects also left heart function, more so the right heart function, and then causes problems with the liver and the kidneys because the right side can't actually unload properly. Next slide. So, if you keep somebody or have somebody has atrial fibrillation and is secondary to mitral valve insufficiency or regurgitation, what we're sacrificing is the following. Is depression of ventricular function, and it is a common cause of end-stage heart disease because the ventricle stops working effectively. You add that with a leaky valve to atrial fibrillation, you got ventricular dilatation, the remodeling that we see in patients that have dilated ventricles. And keep in mind, those dilated ventricles are not different from the stretch marks that we see on skin of patients that either have ascites or Cushing's or any of these medical conditions that cause stria. It's the same thing. If you see it on the skin, it's happening in the heart. And then certainly the risk of pulmonary, of thrombotic complications and pulmonary hypertension are, I don't have to go over because they're clear and each and one of us have experienced that. Next slide. So I guess for you, and hopefully I'll be able to answer this question, when is it appropriate to start sending patients to be referred to for problems that are associated to structural heart disease and causing mitral insufficiency? Well, I would say the decision is primarily based on the severity of the lesion. And keep in mind that nowadays, based on ACC and AHA guidelines, you no longer have to wait for symptoms to develop. Because as I showed you in the slide, a couple of slides ahead, once symptoms start, the clock starts ticking, okay? And so it's very important to refer these patients early when they are known to have mitral insufficiency. And what I usually tell people is that to avoid the end complications associated to mitral valve structural heart disease, like the atrial fibrillation, like the pulmonary hypertension, like the congestive heart failure, as soon as you see that valve being moderate to moderate severe, it's important to get them into a program that knows how to manage these, and particularly a lot of these lesions are repairable. They don't have to be replaced. We don't have to change valves in these, and I have to be proud to say that the grand majority of patients that come through our doors that have this type of pathology, we actually are able to repair and use their own valves to alleviate the disease and not have to replace it with either a tissue valve or a metal valve. Next slide. So a couple of years ago, I decided, I was in Dallas, and I got to Dallas in 2012. And about 3 years into that, I realized that there was something going on the west side that nobody was paying attention to, and that's the city of Fort Worth. And I kept telling my partners, I said, guys, we gotta go out west. And you know, maybe it's me that I kind of have a vision for opportunity, and I see, you know what, I'm gonna go and do these things like I told you when I went to Nicaragua. But nobody got it. It was so frustrating to me. And so, you know, 4 years later, I said, you know what, I'm going to go to Fort Worth, and I established a second practice. And I scanned the area, and everybody who was working there, and cardiologists and heart surgeons alike, were doing one thing. Everybody was hot on TAVR. Boy, I'm a TAVR surgeon. I'm a TAVR cardiologist. And I kept looking around, and I was reminding of the story that Dr. Michael Mack said to me a few years ago. And he said, have you ever heard the joke or the story of this businessman who grabbed his two best salesmen and sent them to an island? I'm like, no, what's the story? And he said, well, sends these two businessmen to a remote island and have them come back with information to see what opportunities there is. And the first one comes over and says, hey, how was the trip? He says, oh, great, sun, beach, whole 9 yards. Says, okay, so what do we got to do? He says, you know, boss, people don't wear shoes over there. Nobody wears shoes. He's like, okay, yeah, I don't know. Okay, well, good. Grabs a second salesman and says, so how was the trip? Same story. Beach was great, sun, coconut trees, palm trees, everything. He says, you know, boss, people don't wear shoes over there. He says, yeah, I know, I heard. He says, we can sell a lot of shoes. Fort Worth was the same thing. Everybody wanted to do TAVRs. But nobody was caring for mitral valve patients. So it was obvious. It was obvious that the opportunity lied in us offering people mitral valve care. And so with that, we founded the mitral valve program in Fort Worth, which the vision was to do it in a multidisciplinary fashion. I didn't want it to be just one doctor. I wanted it to be a number of doctors. I didn't want a patient just come to have my opinion. I wanted the people be seen from every single angle and decide whether they were be treated or not. I'm proud to say, and listen, this is a surgeon talking, okay? I know, it's like the Toyota guy. I'm going to sell you the Toyota. No, trust me. I'm first a doctor. 30% of people that walk through our doors don't get surgery. 30% don't get surgery. A lot of people get followed for a long time. And the reason we have it in our system is to get to them before symptoms start. I just told you, the American Heart Association, the American College of Cardiology said, when it's moderate to severe or severe, then that's when you should do something. Now, if there are cardiologists in the audience, I know moderate to severe is not severe. Get it. So let's not forget that you're lying down on a stretcher, not stressed out, getting an echo. If you put those people on a treadmill, I guarantee you that they all will turn into severe. We can make them look severe. So we started this program, and after we started the program, it really did go gangbusters. And within a very short period of time, we went from just doing minimally invasive procedures, which we do through a 3-inch incision to repair a mitral valve, to catheter-based therapies. And now we offer high-risk surgery patients percutaneous procedures that could be done via catheter. One of those is the mitral clip, and I have to go back. Let's see if we can go back. I have to commend this good-looking guy over here, Dr. Amir Malik, for being the leader of our program right now in doing the mitral clips. And between him and I and the entire group, we're evaluating a number of patients that are coming in that in the past would not have been surgical candidates, but nowadays can receive this type of therapy. Excuse me. Next slide. So how busy we got? This is how crazy busy we got. So when I got there, we were doing about 3 to 5 cases a year, and now we're almost hitting 100 in a short period of time. This is with MitraClip combined. The average busy mitral valve center does about 22 mitral valve repair cases a year. It's a busy one. So look at what we're doing. It's really exciting to see it. And in a city that basically was losing patients to go to either Houston or had to cross the state or going up to the Cleveland Clinic when we have this. Next slide. What was interesting is that with more mitral valve that we were seeing and more patients that had mitral insufficiency, guess what happened? We saw a number of patients also come in that had atrial fibrillation that needed to be treated. Now, the good thing about when we do it surgically, and this is based on studies that have been published in the last 2 years, is that we don't only do surgeries like the cryolanes to get people out of atrial fibrillation. We also take out the reservoir for the clot, which is the left atrial appendage. So you know how there are now, cardiology have these really cool gadgets called a Watchman, just kind of a little cone that they put inside the left atrial appendage to obliterate it. By the time that we do this, what we do is just cut the thing off. Now you don't have to be on a blood thinner because the atrial appendage is cut out. That does not mean that you can't have a stroke, because you can have a stroke for a variety of other cardiovascular reasons. But at least strokes associated to atrial fibrillation because of clot within the left atrial appendage, well, if we eliminate the reservoir, then there's no need to be on anticoagulation because we have obliterated the space. So we have seen a remarkable increase also in the number of atrial fibrillation cases that we've done over the last year. Next slide. And I wanted to show you also how well we're doing when you compare it to the rest of the nation in terms of the repair rate when it comes to treating patients that have mitral valve pathology.